Good morning, guys. Just arrived at work. On the way, one ambulance went by, so we all pulled over. Then literally 30 seconds later, another ambulance went by. No doubt the same incident. So whatever's happened, sounds like it's quite serious, so I hope everything goes okay. It got me thinking. Medicine is full of highs and lows. The highs, we go into this profession to obviously affect a positive change to the individual, hopefully to improve their health. If you're lucky, you get to improve both their physical and psychological well-being. It's always nice to receive compliments, but it's not why we go into the job. We see a value in affecting humanity. I've never been a fan of the machine, so the idea of working within this model of industrialization, materialism, all that crap, it's never ever interested me. So you're expected to improve somebody's well-being through your actions. You are essentially guiding somebody, you are intervening and hopefully affecting a positive change. So the highs are expected, the highs are normal. The lows are horrendous because you haven't affected a positive change. Sometimes you've actually caused a problem. Hopefully, obviously not intentionally, but through your intervention, you can actually cause harm. That can be physical or psychological. More often than not, obviously, it's psychological. So it's very distressing, disturbing, alarming, upsetting to actually cause harm. Funnily enough, you don't go into medicine to cause harm. So you can understand why there is a massive emphasis on safety. It stands to reason, obviously. You can't have cowboys, you can't have mavericks making bold claims, implementing unsafe practices. It's why we have the GMC, it's why we have the NHS, it's why we have NICE, the National Institute for Clinical Excellence, although it's the National Institute for Cost Effectiveness, if we're being perfectly honest. And it's why we have research. Now, I'm going to give you a case study of a guy that came to me recently, just to highlight some of the problems that we face. This guy, mid-20s, bright guy, been to university, but he'd been suffering with the symptoms of low testosterone for a few years. Predominantly low mood. He'd been to his doctor and he'd had the usual antidepressants. So don't look for a cause, here, have some antidepressants. So he'd had 4 different antidepressants. And while some of them had actually had a mild effect. There was a mild improvement in his mental well-being. They did not solve the puzzle. Antidepressants do have a place, but you should look for the cause. Now, this chap, being a bright lad, he sought the cause. And guess what? Testosterone. He had a low testosterone. He had a repeat sample, and he had a low testosterone. According to the British Society for Sexual Medicine, he was or is a candidate for TRT. So, guess what? According to NHS endocrinologists, he is not a candidate for TRT. Now, why is that? Well, I'll tell you. NHS endocrinologists go on abnormal. That sounds logical, doesn't it? Abnormal. If you're abnormal, we want to make you normal. Now, abnormal now is a lower reference range, a lower number than abnormal a couple of years ago. Abnormal changes from region to region. So, according to NHS endocrinologists, there is no national reference range. There is only the local pathology reference range that takes a current sample population and then defines what is normal. So in a sick society, and please don't question whether we live in a sick society, we might live longer, but we don't live better. There are more and more preventable diseases that are having a detrimental effect not only to our own health, but to the health of others. Now, why is that? Because money that should be dedicated towards finding a cure for cancer or progressive research into other aspects like stem cells and all these incredibly fascinating subjects are actually being diverted to managing preventable diseases. So there's a real issue. Now, this needs to be addressed. So not only is there not a national consensus of what is normal within NHS endocrinology, not only is there a lower normal reference range than there was a year ago, 2 years ago, NHS endocrinologists want to find an organic pathology. Now that makes sense. So again, looking for a cause. So much like the depression discussion, rather than simply apply a band-aid in the form of an antidepressant, one should look for a cause. Now that may be a physical cause, such as low testosterone, relative high estrogen, underactive thyroid, or it could be a psychological cause, obviously money, worries, etc. in this peculiar world where we are the only species on the planet that has to pay to be here. Quite alarming, that, isn't it? We are the only species, let that sink in. We are the only species on this planet that has to pay to be here. We are the only species on the planet that is destroying this world. That is very scary. Wow. Let that sink in for a minute. What a peculiar species we are. So, finding a cause makes absolute sense. Why? Because it's obviously valuable information. But really, what we should be looking at is, if we find a cause, can we do something about it? Can we reverse the outcome by addressing the cause? Now that makes perfect sense. So another guy just recently who had a low SHBG, it was 4, I think it was, the NHS endocrinologist sent off a sample to have a gene tested to see if this guy had a genetic cause of his low SHBG. Turns out he did. But they were going to delay his treatment because it was going to take months and months and months for the results to come back. So this guy was going to struggle with the symptoms of low testosterone because the NHS endocrinologist wanted to find a cause, which is what he should be doing, but the result of that investigation would not have affected the outcome, which would be normalization of his male androgen levels. So due diligence would obviously mean that the NHS endocrinologist should have been looking at other causes of low SHBG and reversing them as well. But this guy was fixated on the possibility of a genetic problem because he'd already excluded other causes of low SHBG. So getting back to this guy, finding an organic cause. Actually, no, let's take a step back again, because finding an organic cause obviously is incredibly important for the reasons discussed. Now let's just think about this. Do we always find an organic cause in medicine? And the answer to that question is no. We have a term for that in medicine. It's called idiopathic. It means that we cannot find a definitive cause. Maddie. There's a dog going by. Little. They're always in protection mode when they're with me. So yeah. So it's common in every discipline, every pathology. There is often idiopathic, because whether it be we have yet to discover the organic pathology, or whether it be a multitude of factors that cannot be reversed, doesn't matter. It's called idiopathic. But NHS endocrinologists refuse to use this term when it comes to testosterone deficiency. Now, we know there are obvious risk factors for having testosterone deficiency that are not organic pathologies in the traditional sense of the term. Now, the obvious one is steroids, recreational drugs, opiates, antidepressants, traumatic brain injury, post-traumatic stress. There are lots and lots of risk factors that really should be undeniable. We have rationalization why these risk factors cause testosterone deficiency, but according to NHS endocrinology, you will all recover. Really? Okay. Exactly how long should somebody wait? How long have we got in this world? 80 years, 90 years? Should you wait 1 year? Should you wait 5 years? Often these guys present in the prime of what should be the prime of their lives. So 20s, 30s, 40s. And the debilitating symptoms of low testosterone, low mood, low energy, low libido, have a horrendous effect on both their physical and psychological well-being. Let's draw this back to my guy. He, as I said, is a bright boy, been to university, talking to him, very articulate, insightful. Guess what happened? He turned up a day early, 24 hours early. So bad is his brain fog that he came to the clinic 24 hours early. Bad lad, because I finished late because of him, but it's all good. He's a good guy. He's a good guy. So this poor guy. Of course we saw him. I mean, honestly, he actually travelled 4 hours to see me. Train journey, massive bike ride. So desperate was this guy. And how sad is it that he was that desperate? He turned to the NHS. He'd been given the Band-Aid. He was refused treatment for low testosterone, irrespective of the BSSM guidelines. These national guidelines that are not accepted by NHS endocrinology because of the reasons discussed. So, mentally, brain fog, obviously, 24 hours early, pretty bad. Mood, obviously bad. GP had felt it warranted 4 different antidepressants. In actual fact, he admitted that he had had suicidal ideation. Suicidal ideation, mid-20s. We started a campaign called Healthy Body, Healthy Mind, #ChooseTRT. And the reason why we did that is because we had, again, 2 guys in their 20s within the space of 2 weeks tell me that they would not be here without testosterone replacement therapy. One of the guys, early 20s, he had been eventually been prescribed TRT by the endocrinologist. He'd been prescribed the gel and he'd been offered Nebido, but because of obviously the peaks and troughs that everybody outside of the influence of Bayer understands, that 12 weekly injections is a waste of time. Sorry, Bayer. You should start pushing enanthate a bit better. But don't start pushing it as per manufacturer every 2-3 weeks. That doesn't work. You pharmacokinetics. You do not have to have a... It doesn't work. So, microdosing, small, frequent injections. What are we trying to achieve? Stability. Constant levels from day 1 to day million. Not measuring bloods in a trough after 2 weeks and going, that's satisfactory, but not appreciating that there's been a peak. And now the trough level is the lowest level. Give me strength. I am absolutely flabbergasted. And it comes down to this original point, which is safety, and how regressive this safety culture actually is when it comes to testosterone deficiency, and how there are attitudes there that need addressing. Part of the problem is this false association of testosterone deficiency and TRT with the bodybuilding community. and dare I say, false promises and providers promoting TRT as a lifestyle drug. It is not. It is a drug to correct a deficiency. It is a drug used to hopefully reverse the negative symptoms of low testosterone. Testosterone should not be used in isolation, in my opinion. Hormone replacement therapy. Testosterone suppresses the pituitary. You do not send LH and FSH down to the testicles, and actually LH in the brain as well, remember that. So you are actually causing harm by not replacing the LH. Now we know that HCG replaces the LH. So you will have stimulation of the Leydig cells of the testicles, and you will have potentially fertility. Testosterone causes infertility because of azoospermia, because of LH not being sent down to the testicles. Also testicular size, also well-being and libido because of the stimulation of the LH receptors in the brain. Need I go on? Apparently I do, because people are still not listening. We still have NHS endocrinologists concerned about how we practice. I'm concerned about how you practice. In fact, I'm horrified. There is no one size fits all. So, again, HCG does not suit everybody. But we should be looking at testosterone replacement therapy as hormone replacement therapy. There's a short-sightedness that testosterone, it's not Ronseal, testosterone does exactly what it says on the tin. You need to have an understanding of the hypopituitary gonadal axis. Take a step back. And safety should always be paramount. But you should look at a subject with fresh eyes and appreciate why people don't stay with the NHS, why people do not stay with providers and they come to the men's health clinic. Logical, methodical, progressive. We will always act in the patient's best interests, which is something that I believe you want to do, but you're holding on to your intellectual property, if that's the right phrase, tight as you can. And you are, in my opinion, causing harm. There needs to be a change. There needs to be a shift. We went to the British Society for Sexual Medicine conference last week. Lydia came as my bodyguard. She wasn't protecting me. She was protecting them. So I'm quite happy to stand tall. It's hard, I'm not going to lie, because we face battles, constant battles, not only from the NHS endocrinologists who refuse to accept the BSSM guidelines, they also refuse to accept the validity of HCG associated with testosterone because of its association with bodybuilding. Now, the bodybuilding community only use HCG because the NHS used it in male infertility, And so they put two and two together and said, right, if I'm on cycle, HCG will help preserve my fertility. Rather disturbing, the urologist that spoke at the BSSM conference admitted that bodybuilders know more about endocrinology than he does, and he was very alarmed about this use of HCG. I'm very alarmed that you have such a blinkered approach to patient care, and just because something is used by a community outside of medicine, it should not be dismissed. Surely you should be looking to see if you can use that information scientifically, and you can potentially amend your current practice so that you can improve patient care. I don't think I'm saying anything controversial. I really hope I'm not, because it shouldn't be. But if this is seen as controversial, I will be controversial, because I know the profound effect normalizing melandrin levels has on physical and psychological well-being, if the patient understands that life is not just about testosterone. Life is far more complicated. And so what we try to do at the Men's Health Clinic is adopt a more a more holistic approach to patient care. So on the premise, it seems quite obvious, replace testosterone, replace LH with HCG. But unless you have all the other factors involved in sustaining, maintaining, improving your health in check as well, it's a waste of time. So if you're looking at your lifestyle, looking at your stresses, looking at sleep, if you're looking at your diet, ideally a principled low carb, high fat, exercise, resistance can be calisthenics. There is no one size fits all, but you need to step back as well, as much as the endocrinologists have to step back as well, and not pin all of your hopes on optimization, which is a perverse word, and it's been misused by providers and the Americans across the pond trying to advocate super physiological levels. You need to look at your health as a smorgasbord of many, many, many factors and appreciate the journey. So, God, 28 minutes. I've banged on for 28 minutes. Let's get back to this guy. So, we've commenced him on testosterone cypionate and HCG. I'm looking forward to telling you how he's going to get on, obviously without revealing any personal identifiable information, because after talking to him for an hour and a half, you get an hour and a half for your new patient consultation, because it's an important time. It's an important time for you to share your story. It's an important time for me to get across the information I need to get across, and then make sure that we both understand what I've said, what he said, and we can decide whether TRT is in this person's best interests. Because it comes down to working in the patient's best interest. It comes back to supporting the patient. So one of my other guys recently said that he contacted a provider and he was offered testosterone replacement therapy. And part of their sales pitch was, and the best thing is, you don't even need to see a doctor. The best thing. Now that rang alarm bells in this guy's head, which, wow, fortunately, wow, because he would have been given he would have been given it wouldn't have been the Testosterone 125 crew. It's the other crew, Ananthate. I'm interested to know how you're getting an Ananthate, whether you've got a parallel import or you're just sort of being dodgy. Interesting to find out, but I've got way too many things on my plate to be bothering with you. Yeah, so due diligence, due care, appropriate care. It cannot be overemphasized. Establishing a formal diagnosis, excluding reversible causes, and telling somebody, demonstrating to somebody that you will support them and always act in their best interests.